Good afternoon, everybody. Welcome to the WH&Y Wellbeing, Health and Youth NH&MRC Centre of Research Excellence in Adolescent Health webinar series. And I am Rachel Skinner, and I'm with my colleague Kristen Davies, and we will be presenting today. So I'd just like to first off acknowledge the funding support of the NH&MRC and the contributions of our research partners in universities across Australia. We also acknowledge the traditional owners of the country throughout Australia and recognise Aboriginal people's continuing connection to land, waters and culture. And we pay our respects to their elders past, present and emerging, and any Aboriginal people who have joined us today. As we always do, just point out that you should have a little look at why.org.au, our website, as there's lots of information there, particularly the WH&Y community of practice, where you will find lots of information and discussion and inspiration of importance to researchers, clinicians, policymakers and young people. So just to orient everybody, if you want to chat, so first off, your microphone and your video are switched off, so you can't actually speak up in this webinar, but please interact through the chat function. Any comments that you'd like or any questions you'd like to ask us, we will probably answer them at the end, where we will allow time to answer questions. And so we won't overlook your questions. So please be as interactive as you like. So you can see that chat function at the bottom right of your screen. So just to introduce myself, I'm hosting today. I'm a professor in paediatrics in the Faculty of Medicine and Health at Sydney University. And I'm Deputy Director of WH&Y. And I've had a strong interest in adolescent vaccination over quite a few decades, actually. So, and I'd like to introduce my co-presenter, Kristen Davies, who is a research fellow in the Specialty of Child and Adolescent Health at the University of Sydney Clinical School, and is also a WH&Y researcher. Her vaccination-related research expertise includes vaccination for adolescents and young adults, and vaccination delivery systems, and implementation science and knowledge translation. So today we're going to talk to you about COVID-19 vaccine acceptance and intentions among young people, and we'll present a study that we've recently conducted. We'd like to acknowledge our co-investigators in this study, Associate Professor Pip Collin, Maya Giordano, Tessa Kopp, Sarita Bista, Kirsten McCaffrey, and also our industry partner, Student Edge, and the young people, of course, who participated in the survey. Sorry. And I might hand over to Kristen now, who's going to provide a bit of background.
Thank you so much, Rachel, and thank you so much, everyone, for coming today. I'm actually recovering from COVID-19, so very timely, I guess, that we're giving this presentation. So adolescents have similar infection rates to adults, although the severity of illness is less, and severe COVID-19 disease in adolescents is very uncommon and only very rarely causes death. However, there are substantial indirect effects for adolescents and young people, and these are mental health, learning and physical well-being of adolescents. Obviously, school closures have had a massive impact on young people, lockdowns, not being able to socialise with their peers, psychosocial distress, and also loss of income and jobs and unstable housing have all impacted young people. And also young people are differentially impacted with those most disadvantaged suffering the most at this time. Thanks, Rachel. The benefits of vaccination include strong immunogenicity and vaccine efficacy against symptomatic COVID-19. And vaccination also reduces infections, hospitalizations and deaths due to COVID-19 and other complications such as pediatric multisystem inflammatory syndrome associated with SARS-CoV-2 and also long COVID. Vaccinating adolescents contributes to reducing cases in the broader population and therefore will reduce the indirect impact of the pandemic, such as reducing disruption to education, reducing potential transmission and outbreaks in schools in particular. Thank you, Rachel. Rachel, you're on mute.
I'm going to talk a little bit about the epidemiology of COVID-19 as we've experienced it, particularly since the start of the pandemic, and how it's affected young people, just to set the scene. So with the first wave of COVID-19, as you can see by the breakdown, this curve here, this is the alpha wave, that first wave that we had in early 2020. And the group that were most impacted really were the older age groups, but also mid-adults. And then this slide here gives the percentages of cases by male and female, and a background. The black bar is the background population. So it gives you a sense of which age groups are overrepresented or underrepresented in terms of the background population in the case the case breakdown. So in this early first wave, we saw an underrepresentation of the youngest age groups, but an overrepresentation of this sort of young adult and sort of mid-adult age groups, and then a relatively appropriate representation for the older age groups. Then moving along to the Delta wave, which happened, as you know, in the middle of towards the sort of middle, moving on to the second half of last year, so September in particular. And you can see the breakdown by age here as well. And so this older age group, the case rates are lower actually than the younger age groups that are higher. So the younger age groups, are starting to experience a higher proportion of the cases in the population. And if we look again at this graph, which shows the differences between males and females and the background population, we can see an overrepresentation now of this younger age groups for both male and female, and also that sort of young adult and even mid-adult, but an underrepresentation of the older age groups. Now this is due to a number of things, but most importantly because we focused on vaccinating the older age groups first. So they had the protection of vaccination before the younger age groups, and there was a period of catch-up of vaccination coverage in the younger age groups. And so it's partly as a result of that, but it's also a result of the behaviour of young adults and younger people. They're much more social. They go out and mix with lots of different people. So they're very efficient transmitters of the virus. And I might just skip over this one. This is the Omicron wave. So the Omicron wave, which really began in December or late November. And you can see the breakdown of the different age groups here represented in the different colours. So if we look at this first peak, you can see that's the young adult age group, and that sort of younger mid-adult age group is in that sort of peak. And then this is the teens comes next. And then if we go further along, getting into March after school started, we can see that this group here, the 10 to 19, is the one that is the highest peak there. So it's just interesting to look at the different age groups and how they are how the proportion of cases is represented by age group, and to be thinking about what the reasons for that is. I mean, there are different reasons. So one is vaccination, and the rollout of the vaccination program, that younger age groups were able to access the vaccine only more recently than the older age groups. But it also relates to those other activities of being in contact with other people, with lots of other people, particularly in social settings and in schools. So looking at where we're up to with vaccination coverage, I have to apologise to people who are in other states that I'm presenting New South Wales data, because I'm very familiar with the New South Wales data, but I think it's very similar, in other states which have experienced the COVID pandemic in a similar way to New South Wales, at least. So we have, as you can see, higher coverage for 2 doses of COVID vaccine in people aged 16 and over than people aged 12 to 15 and people younger than that. You can see that it's dropped right down, and this is the most recent data that we have. For 3rd dose, so booster dose, it's only eligible people who are 16 and over it's only recommended in that age group, so we see that the coverage is just around 2/3 of the population. And it's just interesting, I'll show you this other slide, which is a little bit older, but it shows you how the coverage has really flatlined since around late November, which is approximately the time when we did the survey that we're going to present to you. So as you can see from this graph, there is really no change in the coverage rates since then, or very little. And we wouldn't expect that has changed since either, because there haven't been any major campaigns to boost the coverage since. So I'll hand over to Kristen to start to present our study.
Thank you, Rachel. So at the time that we'd conducted our study, there'd been one US study in parents and adolescents which found that parental concerns about vaccine safety were of concern. There was social media was a negative influence about vaccine safety for young people, and there were demographic factors associated with known inequities in vaccine access. And there are no Australian studies published about this age group as of at the time that we did the study and currently. Thank you, Rachel. So our aim was to measure factors associated with completion of a 2-dose COVID-19 vaccine schedule, and also intention to receive a booster dose. And our hypothesis was that low 2-dose vaccine completion and intention to booster would be associated with factors common to lower vaccine coverage for other vaccines. For example, disadvantage and minority status, attitudes such as low perceived severity of disease and low perceived efficacy of the vaccine, and also concerns about vaccine safety and efficacy. We designed a national online cross-sectional survey, and the setting was Australia-wide. The survey was open from the 10th of November until the 3rd of December 2021. Our participants were aged between 14 and 25 years and were recruited from a large nationally representative online panel through our research partner Student Edge. And we examined the correlates of having 2 doses of a COVID-19 vaccine and also intention to receive a booster or a 3rd dose. And at the time that we conducted the survey, the booster dose was only recommended for those 18 and plus. However, we asked the question about a booster vaccine for all ages regardless, assuming that this would be recommended in the future. And as Rachel indicated, obviously boosters, meaning a third dose, not a fourth dose, are recommended for young people aged 16 and 17 years old. The other thing to note is that we also boosted our sample for New South Wales. We're actually collaborating with New South Wales Health, and Rachel will talk a little bit about that later. So about a third of the sample was from New South Wales. Thanks, Rachel. So special thanks to Maya, who brought together this fantastic timeline to just provide a bit of a snapshot of what was happening at the time that we conducted the survey. So at the time, the reported national case numbers started at around 17,979, and 84% of those case numbers were in Victoria, and this dropped to 15,997, and still about 81% of that load was in Victoria. There was lockdown at the time only in the Northern Territory until the 4th of December, and New South Wales and Victoria had come out of lockdown, but restrictions were starting to ease at this time. So the vaccination rate was around 80% for at least one dose across most jurisdictions, except WA, which had a slightly lower rate at just under 68%. The booster dose was available, as I had mentioned, for 18 plus across Australia, and schools had reopened in Victoria on the 5th of November and in New South Wales on the 24th of October. Various state borders were closed, so we weren't able to travel easily interstate. And also the first reported case of Omicron, apologies, was on the 26th of November in Australia. And from the 27th of November, we had some international restrictions. So, for example, we weren't able to travel to South Africa. At the time, at the start and the end of the survey period, 20 to 29-year-olds and 10 to 19-year-olds were the first and third numbers of cases, highest cases by age group. Thank you, Rachel. I'll hand over to Rachel now. Thank you.
Yeah, so we recruited just over 1,600 young people, and age 14 to 25, and of those 48% were male and 52% female. We also asked about gender, 48% male, 50% female, and 1% non-binary, and 1% other term. We asked about sexual orientation, so 80% of the sample were identified as straight or heterosexual, 3% identified as lesbian or gay, 9% as bisexual, and 8% as other. We had 3.9% Indigenous of young people living in regional and remote areas, 16.5%. Young people who spoke a language other than English at home, just 33%, a third. And coverage data, so of the sample, 83% had received 2 doses of COVID-19 vaccine on self-report. So we looked at what factors were associated with having had 2 doses of the COVID-19 vaccine. So unsurprisingly, given the rolling nature of the recommendations of older age groups down to the younger age groups, having an older age was associated with 2-dose completion. So 2 doses, as you can see, the difference is only small at both 19, but 19.3 versus 19.7 for the 2 doses group. Participants who were of female sex were more likely than those of male sex to have 2 doses of the vaccine, and also those of female gender. So those who were participants who were not Aboriginal and Torres Strait Islander were more likely to have had 2-dose completion, 84% versus 64%. Those living in urban areas, so urban 84% versus rural areas, 76% had 2-dose completion. Interestingly, speaking a language other than English at home was more likely at 88% to have a 2-dose completion compared to those who only spoke English at home. And I probably should just say that this was at the time when there was the lockdown in South Western Sydney and the Western Sydney LHDs and LGAs, LGAs. So there was a huge push in those areas to vaccinate the population. And there was a great motivation as well to vaccinate. So that perhaps explains what we would not expect with other vaccinations. So higher SES, according to the CIFA scale of 1 to 5, those in more socioeconomically disadvantaged areas compared to advantaged were less likely to have 2-dose completion. We looked at well-being and attitudinal and informational correlates of 2-dose completion as well. So we measured psychosocial distress using the K5 tool, Kessler-5, and we found that overall there was a very high level of psychosocial distress, much higher than we would expect generally from other population surveys pre-pandemic. And what we did find that those who had higher levels of psychosocial distress were more likely to be have had 2 doses of the vaccine. Interestingly, those with chronic conditions were no more likely to have 2 doses, but they were still very was still high coverage across the sample. But those who had a chronic condition versus those who didn't, there was really no difference. And then we looked at intention to have a booster, and it was if they had 2 doses, or if they had not had 2 doses, they were unlikely to intend, or more unlikely to intend to have a booster, versus those who'd had 2 doses, 92% were more likely. So those who'd had previous COVID-19, if they'd had pre-COVID-19, they were actually less likely to be fully vaccinated versus those who hadn't. And those who had personal concern about COVID-19, yes, so 89% of those had had 2 doses versus those who were not concerned. Unsurprisingly, they had a lower 2-dose completion. Those who perceived higher COVID-19 vaccine efficacy were much more likely to have had 2 doses at 93% versus 44%. Those who perceived a higher public health threat of COVID-19 were much more likely to have had 2 doses. And those who had higher e-health literacy scores in the scale that we used were more likely to have had 2 doses than those who had lower e-health literacy. And those who rated government information sources in their top 5 were more likely to have had 2 doses. So we then did a multi-variable, we then put in all of the factors, all of the correlates into a multivariable model to see which were independently associated with 2-dose completion. So some of those correlates did drop out, but older age remained. So that older age group, 22 to 25, versus the younger age groups. Speaking a language other than English at home versus English only, they had a higher odds of having 2-dose completion, and also if they were in a lower versus a higher CIFA quintile, they were less likely to have had 2 doses. So SES advantage predicts 2-dose completion. Higher levels of psychosocial distress were also found to be just significantly significant. The higher odds of 2-dose completion, and that was just statistically significant in the model. Higher perceived vaccine efficacy versus perceived vaccine efficacy not effective. So the odds of if the young person perceived that the vaccine was not effective, their odds of 2 doses was much lower. So that was an important predictor. And also higher perceived public health threat was significantly associated with 2-dose completion. So then we looked at intention to have a booster. So knowing that there was only that recommendation for the 18 to 25 age group of our sample, but thinking that that would extend potentially in the future, that might extend to the younger age groups. We asked it of everybody. And we did, so without going into great detail on the percentage who intended, I mean, it was overall, it was approximately 65% intended to have a booster, so not as high as the 2-dose completion. And again, we found similar socio-demographics, older age versus younger age, having a greater intention. Not surprising, it was recommended for them. Being female predicted a greater intention. Being non-Indigenous or not Aboriginal and Torres Strait Islander, living in an urban versus a rural area, living in an area of higher SES or higher socioeconomic advantage, and having a chronic illness in this univariate analysis was associated with intention to have a booster. In terms of attitudes and well-being, no previous COVID-19 was still associated with intention to have a booster. Personal concern about COVID-19, about catching COVID-19, and then sort of thinking about it from a population level, COVID-19 perceived as a public health threat to the community was associated with having a booster. If young people reported that they had barriers to accessing the vaccine, like not being able to go to the doctor or the pharmacy on their own to get the vaccine, or not being able to leave school, were the sorts of barriers that were put to young people. And so if they didn't report any barriers to accessing the vaccine, they were more likely to intend to have a booster. Those who reported higher perceived vaccine efficacy and higher e-health literacy were more likely to intend to have a booster dose. And then those who'd nominated government websites, but also health professionals as information sources, were more likely to intend to have a booster. So when we put all of these variables into a multivariable model, what we found was English spoken at home versus language other than English actually predicted a greater intention to have a booster. So if they spoke another language, a language other than English, their odds of intending to have a booster versus those who spoke English was 0.8, so it's reduced. So if they lived in an urban versus rural area, they were more likely to intend to have a booster. If they lived in areas of higher advantage, they were more likely to intend to have a booster. Or on the other, the way it's presented there, the odds ratio of 0.5 relates to lower CIFA quintiles versus higher. If they'd already completed 2 doses, they were more likely to intend to have a booster. So if they'd only had 0 or 1 doses versus 2 doses, the odds of intending to have a booster were much less. Those who reported no access barriers were more likely to intend to have a booster. So if they had a barrier versus no barrier, the odds that they would intend to have a booster is only 0.2, so much lower if they had barriers. High vaccine efficacy, if they perceived high vaccine efficacy, they were more likely to intend to have a booster. If they perceived COVID-19 as a public health threat, they were more likely to intend to have a booster than those participants who didn't. If they had higher COVID-19 e-health literacy, they were more likely to intend to have a booster than those who didn't or had lower COVID-19 e-health literacy. And then those who'd reported in their top 5 information sources a health professional were more likely to intend to have a booster than those who did not include a health professional. So, so just if you can keep all of those things in mind, what we're going to move on to some of the qualitative findings. So I suppose that I just bring back to thinking about some of these things. Some of these, so this is different to the 2-dose. So we found what we'd expect. The English spoken at home, they're more likely to be intend to have a booster. That is what we see as a correlate of vaccination generally. Urban settings, urban locations have higher coverage rates as well, higher socioeconomic advantage. All of these things is what these socio-demographic correlates are what we expect. And it's interesting that how important these other correlates are. So perceptions, perceptions of barriers to accessing vaccination has an influence on intentions. Perceptions around how well the vaccine works, and then perceptions about COVID-19 and how much of a threat it is to the community generally. And then these things are really interesting, that they're higher e-health literacy and who they access for information. So these are the sorts of things that we actually don't know much about with adolescent vaccination, certainly not with COVID vaccination. We do find some of these associations with adolescent vaccination more generally, but it's particularly pronounced in this study, which is interesting. So I'll hand over to Kristen now, who's going to talk and provide a little bit more of a picture to the participants who contributed, who completed the survey and provided more detailed responses.
Thank you, Rachel. So we actually asked, the survey was 10 minutes, so it was pretty quick. So we really had to focus on key information. And we put in a qualitative question because we wanted to understand in particular why young people were not getting a booster. So I'm just going to present some data here regarding young people who indicated that they were neutral with regard to getting a booster, and also those unlikely and highly unlikely to get a booster. So regarding those who were on the fence, if you like, about getting a booster, of those that responded neither likely or not likely to get a booster, they were mainly from city and urban areas. They were more likely to be over 18 years. And just to recap, our sample is 14 to 25 years. They were slightly higher proportion were male compared to female. And the majority had received at least one dose of a COVID-19 vaccine. Thank you, Rachel. So this is regarding the young people who provided qualitative responses who were neutral about their intention to get a booster. So reasons for hesitancy: only if required, and some indicative quotes from young people are: only if I'm required to get it, it's not necessary, I only wanted it for freedom. And then not needed or not necessary, so not against a booster but don't know how needed it is. Young people indicated they were unsure of the vaccine effectiveness and safety. And young people said it depends on the safety and testing of the booster as well as the purpose of the actual booster. And another young person said because it seems to have significant health risk with unknown health benefits. Some people were open to having a booster, and that was indicated by: if I already am fully vaccinated, what do I risk getting a booster shot? So that's risk going in the other direction, if you like. Some people, young people, just didn't know and said, I don't know if I'll need it. Young people expressed concerns about side effects, so undecided about the booster shot as the side effects could be severe. Some young people thought they might be safe to get the booster because it'd be safe and protected. So to ensure I'm protected from getting the various the variants as well as symptoms. And some young people indicated a need for more information or research. So not sure we'll see the information released. And also I'd like more information about how it's better or more effective than what I've already received. So that's all the logic behind young people who are neutral or on the fence about receiving a booster. Thanks, Rachel. And these are the reasons provided by the young people who said that they were either unlikely or highly unlikely to receive a booster. So only if required was very popular. So I will only get it if it is mandatory to do things I want to do. And I was forced to get the first two. And I have to say these kinds of responses were much more common in young men than young women. So the mandates really did have a very strong impact, particularly people who needed to get that to be employed. So, for example, people working in construction in the building industry. Many young people indicated that they believed it wasn't needed or necessary, so 2 is enough and I don't want to. There were concerns about side effects, so much uncertainty on how effective it is and scared of side effects. And then a lot of young people had 1 dose of the vaccine and then had side effects, and that put them off getting further doses. And that's indicated by I had horrible side effects from the first dose. There were concerns about safety. So because it's only provisionally approved by the TGA and I don't consent to being part of a medical trial, that was not uncommon, that kind of response. Some young people thought that the booster dose undermined the first 2 doses. So I just feel like they said we have to get 2 doses and now all of a sudden we're thinking of getting a third. What other vaccine has ever required 6 monthly boosters? Some younger people expressed needle phobia, so they didn't want another needle. They were sick of needles. And some young people indicated they were against COVID-19 vaccination, so I don't like the vaccine. And other young people indicated that they needed more information or research, and by saying, I'm not planning on getting the vaccine as of yet. I'm unsure about the level of testing that has been done. Thank you, Rachel. So we actually put together a case study. This is a real case study from using the data from the survey. And this is a young person who is neutral about receiving a COVID-19 booster. And we thought we'd present this in order to sort of generate conversation. So this young person was aged 20. They lived in Chester Hill in New South Wales. They identified as heterosexual. They're actually female. And case 1's father was born overseas and she speaks Arabic at home. She attends university and works casually. She gets most of her information about COVID-19 vaccines from uni and then her parents and family and news on TV, radio and websites. Regarding a COVID-19 booster and COVID-19 vaccination, case 4 reported the waiting time is too long to receive the vaccine. If she had the vaccine, she'd like to have it at a big vaccination centre or hub. Her most trusted sources of information are university, followed by TV, radio and websites, and then her doctor or pharmacist. She would be concerned about getting a COVID-19 booster because she might not know the side effects. And case 1 believes that COVID-19 vaccines are moderately effective at reducing someone's chance of catching the virus and of passing the virus on to others. And she also reported poor mental health across the Kessler-5 scale. And we just wanted to point out a couple of things. And Rachel, would you like to make some observations about this case with regard to some of the barriers that this young person might be experiencing?
Yeah, I think it is interesting to see where they're finding their information, where they're accessing their information, because that is an avenue through which we can reach the young people, particularly those who are neutral on the fence about accessing a booster. I mean, she's eligible to have a booster, so. And we also noted this in the quantitative findings, that certainly the doctor or the health professional is a very important mechanism for getting that information. And whenever a young person sees the health professional, we generally recommend when it comes to vaccination more broadly, not just COVID-19, that a doctor should make a recommendation to have a vaccination there and then if the person is eligible and they're not, they haven't been vaccinated. And that should apply to COVID-19. So checking on vaccination status and providing information and making a recommendation to have the vaccine. But clearly for her, the university is another source where we could it's another channel for getting information in way, and also designing the information in a way that's appealing to that age group is really important. So, as public health providers, we need to engage with young people and communicate with them in the ways they want to hear, or the ways that resonate with them, and the channels that they access.
I also note that the young person speaks Arabic at home, so it would be really great to have resources translated into Arabic so that she could have discussion with other family members about getting the vaccine. And it might be useful for community groups and NGOs to have that information at hand in case she wants to access that via a website through her community groups as well. Also, she's quite time poor, so I'm assuming she's attending university, working casually. So while she said she wanted to go to a vaccination centre, it's really important that there are walk-ins available for young people, and that often can happen in a pharmacy setting, sometimes at a vaccination hub, but largely young people had to book. So these are some of the other barriers, and I'm sure other people have excellent observations about this case as well, but we might move on to the next slide. So we found...
No, go.
Sorry, Rachel. We found socio-demographic correlates of acceptance and intention to vaccinate were similar to other socio-demographic correlates for vaccination more broadly, and attitudes about vaccine effectiveness, perceived COVID-19 threat, and e-health literacy were strongly associated with intention to receive a booster. Governments and health organisations should deliver practical information and training to support young people's skill development to find and act on quality COVID-19 vaccination. I'm just going to hand over to Rachel because we actually did work with New South Wales Health as part of this project, and she'll give you a little bit more information about that.
Yeah, so in my role as Senior Clinical Advisor for Youth Health in the New South Wales Ministry of Health, I'm also I have been the COVID clinical lead for youth. So we worked with the State Health Emergency Operations Centre Strategic COVID-19 Communications team to help them design messaging for young people. So, adolescents as well as young adults who were clearly a target group at that time for boosting vaccination coverage and also just to communicate messages about COVID-19 and how to prevent the spread of COVID-19. So we drew on the findings of the research as well as our own knowledge about young people and the sorts of the types of communication that would be that would resonate most with young people and the channels through which they access information. So social media, the various social media channels in particular. So yeah, together we designed with young people's input. We designed youth-friendly communications, and which were then disseminated through social media channels broadly to young people, and they were regularly updated. So that was all during that so the second half of last year in particular, and earlier this year. So I think it's sort of shows how it's an example of trying to do research that can inform policy in a real-time way. We haven't yet published this work, so but we're about to submit a manuscript for publication. But as you can see, the urgency of vaccination and controlling COVID-19 has reduced. The perceptions around that generally in the community have reduced, and we no longer have the restrictions that we did have. So, publications take a long time to disseminate. So it's really important, to be able to translate the findings that we have directly to the health department who are managing the pandemic. And so that's what we tried to do as much as possible.
Go to the next
And
slide.
and I probably should say that it wasn't just me, but it was a whole team, and it included also Youth Action, which is another, is a youth peak group, but also WH&Y and Young and Resilient, and our co-authors on this paper, and young people, the WH&Y commissioners were involved in developing those communications for New South Wales Health. So yeah, these are our recommendations that that we have conversations with young people about COVID-19 vaccination and their beliefs and their behaviour. So we need to open up the conversation, and we need to, if they have any concerns or questions, that's an appropriate time to speak to them about it. And if they have myths and misconceptions, to explore those beliefs, understand where they're coming from, and then provide correct information in a non-judgmental way, and direct them to reliable sources about COVID-19 and vaccination. And there are some really good resources that have been developed by the National Centre for Immunisation Research and Surveillance on this slide. Decision aids for parents, and also for children under 16. And as I mentioned, those series of communication messages, they're videos that were disseminated through TikTok and Instagram. And ANCS has quite a number of other resources around COVID-19 vaccination acceptance more broadly in the adult population, and frequent, and also for parents of younger children, and frequent asked questions. So I think that's our last slide. We have some references as well to back up some of the earlier comments we made, in if you were interested in further reading about this topic. So thank you for your attention. We might see if we can answer, if there are any questions, we'd be happy to answer them. So yeah, thanks, Kristen. So I think that there is a question from Dan. And yeah, so a couple of quick questions about the quant analysis. Were any non-linear relationships tested, e.g. between stress and intention? And 2, I assume ATSI status would become significant with greater sample size. Any comments on the likelihood of this? So I'm going to answer the second one first, Dan, because it's easier for me to answer. So while Aboriginal and Torres Strait Islander status was associated with, in the univariate analyses, so just simple correlations, it was associated with a lower 2-dose completion. It was not that characteristic, so being Aboriginal and Torres Strait Islander, was not associated with 2-dose completion or intention to have a booster dose in the multivariable model. So I presume that it was accounted for by the by other factors like SES and rural versus urban location. So it's and while that group, while Aboriginal and Torres Strait Islander people do have lower coverage for other vaccines in general, quite significant efforts have been made, at least through New South Wales Health I'm aware of. I mean, I'm not so familiar with other states, but enormous efforts were made to engage with communities and to co-design messaging to explain the threat of COVID-19 and the importance of vaccination. So I think that even if we had a larger sample size, I mean, it's possible if we had a very large sample size that might show an association, but I do feel that it's other factors that are the most important. So SES and, living in rural and remote areas. And with respect to the statistical question, I have to say no, we just undertook fairly straightforward analyses at this stage, but would be very happy to get some advice from you, Daniel, if you would like to make any suggestions. So that psychosocial distress and intention question. So distress was not associated with intentions, while it was associated in the multivariable model for 2 doses. So we need to do further exploration around that. But I do think that there are some statistical issues with the distress because such a high proportion of the sample experienced were experiencing high levels of distress. That may have an impact. I'd be interested to hear what people think, and we will be doing further analysis on the issue of the psychosocial distress and why these young people were so distressed during that period of time. And it certainly will be interesting to look at whether that has continued, and that's something that researchers should continue to look at, and also health departments as well. So we have another question from Sharon. How successful do you think social media was for communicating with young people? I'm going to hand that one over to Kristen. Would you like to answer that?
So I think social media is really important to young people, and that's how a lot of them are receiving, either accurate information or misinformation or disinformation. And indeed, I think Melody, who was on this, is investigating this in her thesis, and will be using some data to dig more deeply into that very question. But we got really great anecdotally from young people with the co-designed communications that we did. We got great feedback from many young people. So I think what is incredibly important is that we have co-designed communications with young people for young people, and also, of course, health experts working in the area, and parents and the communities. But certainly the communities that are involved in the communication should be involved in an integrated knowledge translation way from inception to dissemination, and that's what we tried to enact using this research. So I hope that answers your question, Sharon. Great question.
Now, this is another one for you, Kristen.
Yes, so as many of you will know, I advocated at the UN for the UN Human Rights Council a few years ago regarding collecting accurate data around gender and sexuality in particular. So great question, Fiona. Thank you so much. We used the ABS standard for sex, gender, variations of sex characteristics and sexual orientation variables. And they're very excited that we were using this because it's one of the first studies to use it that isn't specifically doing research on sexuality and gender per se, but is actually using the measure as part of a different topic area such as COVID-19 vaccination. We've worked quite closely with the ABS in order to analyse the data. So hope that answers that question.
Yeah, so I think that everybody, all of you researchers out there, you need to go and look at the ABS standards for collecting gender and sexuality information and make it a routine part of socio-demographic data collection. So Keith from Myanmar has asked, what kind of COVID vaccines did you provide to children under 18? Is that the similar one that adults received? In our country, vaccines are only provided to adults over 18 years of age, and children under 18 did not receive the vaccine. So we have mRNA vaccines that are available for adults as well, that are the vaccine that's recommended for teenagers and children. So So I suppose the question is really about resourcing and the benefit of vaccination at different age groups. And given that the oldest age groups experience the highest morbidity and mortality associated with COVID-19, they are the age groups that were prioritised at the beginning of the pandemic in Australia and generally are prioritised across the world. And where there's an issue of resourcing, so that, these are expensive vaccines, so perhaps a country can't afford to or justify providing vaccine to all age groups. It is true that adolescents and children have a much lower morbidity and mortality associated with COVID infection. They, in our country, I mean, they still experience morbidity and can die, and very infrequently, very rarely, but it's not common. But they do play a role in the transmission of the virus. Now that we have different strains, it's not clear how effective the vaccine really is in preventing transmission of the virus, as everyone would now appreciate that despite being vaccinated, we're still contracting COVID-19, so it's clearly being spread still, but it still has an impact on reducing severity of disease. So, Keith, I hope that answers your question. But I think that, you know, different vaccines are available in different countries globally, but that's the one that we have. So I think we've come to the end of our questions. Oh yes, so we wanted to do a shout out to an upcoming event, the WH&Y Research Pride. I'm going to hand over to Kristen to talk about this.
So we'd love to invite everyone to this event. It will be on Wednesday, the 29th of June, from 6 p.m. in the eastern states, and it's Y Research Pride. So what's the best way to engage and approach LGBTQIA plus young people in health research, and what works well and what we can improve on? And Pride Month is celebrated in June in many countries, and it's to celebrate the diversity of the lesbian, gay, bisexual, transgender, queer or questioning, intersex and asexual or agender community. And we really look forward to inviting you to this very exciting event.
Thanks, Kristen. And thank you to the WH&Y commissioners who've organised this. Okay, so I think that's it. So I'm going to finish with just a couple of minutes to spare, but thank you all for your attention, and also there will be, and just to let you know that we'll see you again in a month. We'll send out the information for the next WH&Y webinar. So if you have any other questions and you want to get in touch, so I noted Daniel said he would, so that'd be great. So I might say goodbye to everybody, and thank you.
Thank you so much, everyone, for attending. Bye-bye.